Gives me great pleasure to invite our final speaker of the day, Professor Patricia Liaw, who's here from McMaster University. Dr. Patricia Liaw is a tremendous figure in the Canadian Critical Care Translation Biology Group. She's the current chair of the Translation Biology Group. Here at McMaster, she holds the Jack Hurst Professorship in Thrombosis, and she studies various mechanistic ways how thrombosis, coagulopathy, and inflammation influence sepsis pathobiology. And she's here to tell us about her translation biology research, and her talk is entitled Advancing Sepsis Prognosis Treatment Through Preclinical Studies. Thank you.
Thank you for the kind introduction, Alex, and it's wonderful to be here. I'd like to thank Sepsis Canada for the opportunity. So as Alex mentioned, I am in the Department of Medicine at McMaster University, and my lab and office are actually based at the Thrombosis and Atherosclerosis Research Institute. And as the name suggests, most of us work on different aspects of blood clotting or arterial disease. But we're also located right next to the Hamilton General Hospital. So when we moved to the building around 10 years ago, it provided a wonderful opportunity, at least for me, to investigate some of the mechanistic links between blood clotting, inflammation, and infection. And also, being right next door to Dr. Alison Fox-Robichaud, we've had a great collaboration over the years. Alison has provided a lot of mentorship and clinical insights. The one challenge with Alison is that she's incredibly busy. So I've tried for 3 years to book lunch with her. The closest I got was January of this year, and then we got a snow day. So I'm still waiting, Alison. Okay, so preclinical research, as the name suggests, is simply any type of research about a drug or therapy for a disease that occurs before it's tested in humans. So this could involve in vitro studies where we're looking at cells or tissues. It could involve animal models, and for most of this in sepsis research, that would be mice. The challenge in sepsis, as we heard already, is that there have been over 60 clinical trials performed involving over 22,000 patients. And despite early promise in the preclinical animal studies, none have resulted in new treatments. Some of these trials included interventions that target inflammation, or they neutralize bacterial endotoxins, or even anticoagulants. As we already heard as well, part of the challenge is that sepsis is a heterogeneous, life-threatening, I guess I shouldn't use disease anymore. It's syndrome, right, Alan? Okay. Heterogeneous, life-threatening syndrome. There are many different sites of infection and many different types of infection. And in terms of the barriers, they can be broken down into 3 general categories. So the target of therapy, what is the correct target? And are we using the correct animal model to test some of these targets? The timing of therapy is also a challenge because the onset of sepsis and disseminated intravascular coagulation are often ill-defined. Third, there's heterogeneity in patients and process of care. So stratification systems are needed to guide treatment decisions. Over the past several years, we've been looking at novel targets of therapy. And what we found several years ago in a prospective multi-center observational study is that blood samples from ICU patients with sepsis have very high levels of extracellular DNA. So DNA typically is supposed to be inside the cell in the nucleus. Why is it in the circulation? We found that DNA is released mainly by activated neutrophils, so a type of white blood cells. And it's a active form of cell death called mitosis. The DNA is a potent trigger of blood clotting. So if you take whole blood and you just add purified DNA to the blood, it will clot faster than adding kaolin or the APTT reagent. The DNA also alters the morphology of the blood clot, so it makes the blood clot completely resistant to digestion with antifibrinolytic or fibrinolytic agents such as TPA. They also provide a three-dimensional scaffold that trap not only red blood cells and platelets, but immune cells such as neutrophils and monocytes. So this process is called immunothrombosis, and it can be thought of as active participation of immune cells in forming blood clots. And this is a hallmark of sepsis. It does facilitate the recognition, containment, and destruction of pathogens, but excessive formation of these clots can result in microthrombi, particularly in the small vessels. So this is just a very general schematic diagram of some of the common mechanisms of infection-induced immunothrombosis. Regardless of whether the infection is viral, so in the example of COVID-19, it would be the SARS-CoV-2 virus, or if it's bacterial, both bacteria and viruses can initiate coagulation. In the case of bacteria, they'll bind to pattern recognition receptors and will upregulate tissue factor. So tissue factor is the physiological initiator of blood clotting. Viruses will hijack the host tissue factor expressed by endothelial cells or monocytes. So high levels of tissue factor in the circulation will immediately trigger coagulation. Clotting will activate platelets. The release of inflammatory cytokines will cause endothelial injury. Platelets, neutrophils, and monocytes are activated. And the end result are blood clots that contain not only platelets and fibrin, but also high levels of immune cells and extracellular DNA. So it's a double-edged sword because it does provide protective effects by helping to trap and destroy microorganisms. However, they can also exert harmful effects by impairing tissue perfusion, causing systemic endothelial injury, which may lead to disseminated intravascular coagulation. So we thought, why not just administer an enzyme that can break up these clots? There is an enzyme called recombinant DNase 1, which is improved as a nebulized therapy for treatment of patients with cystic fibrosis. We thought intravenous administration of DNase 1 may be helpful to digest away the clots. The enzyme works by degrading the phosphate backbone of DNA, thereby liberating many of the constituents of the blood clot. In animal models, we found that intravenous, actually, IP administration of this enzyme not only reduces organ damage, but it improves survival. So we've shown this in an acute model, as well as in a less severe model where the mice were monitored for up to 72 hours. What we found in these studies is that the timing of the therapy does matter. So administration very early on in the course of sepsis was harmful, presumably because you do need the neutrophils to release the DNA to trap and contain pathogens. But delayed administration appears to be beneficial. In patients with sepsis, and this was a multi-center prospective observational study of almost 400 ICU patients, we found that patients with very high levels of DNA have poor outcome. And this was done in collaboration with the Canadian Critical Care Trials Group, as well as the Translational Biology Group. We also measured the levels of this enzyme in ICU patients. We found that unlike the levels in healthy volunteers, there is an acquired deficiency of DNase 1 in ICU patients with sepsis. And the deficiency persists throughout their stay in the ICU. So we received from CIHR a 3-year grant last year to look at the safety and feasibility of administering intravenous DNase 1. This is a phase 1 open label dose escalation and safety study. We're proposing 2 different doses of the drug administered intravenously for either 3 days or 7 days. The study has already been approved by Health Canada. It's finally approved by the Hamilton Integrated Research Ethics Board. And Allison, correct me if I'm wrong, but I think we're finally good to go. So looking forward to this. The other barrier is the timing of therapy, given that the onset of sepsis is often ill-defined. This is because we can think of sepsis as falling along a continuum of pathophysiological states. So the initial infection could be cleared, which results in the resolution of inflammation. But if it's systemic, this could result in sepsis, septic shock, multiple organ failure, and ultimately death. In the COVID literature, there have been at least 3 clinical trials which have shown that therapeutic dose heparin is beneficial in moderately ill, but not in critically ill patients with COVID-19 related sepsis. So this has refueled our interest in heparin as a potential therapy for sepsis. So heparin is best known for its ability to inhibit blood clotting. It's a very heterogeneous, highly charged, negatively charged glycosaminoglycan, but it also has anti-inflammatory, antimicrobial, and cytoprotective properties. In fact, 70% of the heparin molecules in clinical grade heparin are not even considered anticoagulant because they lack the antithrombin binding sequence. So we've shown that one of the protective effects of heparin is that it does have the ability to neutralize histones, which are one of the most toxic molecules that are released from activated neutrophils. So we discussed how extracellular DNA can help to increase the size of blood clots. Histones are actually the most abundant proteins released by neutrophils. They can activate platelets, they kill endothelial cells, and they can upregulate tissue factor expression, which then triggers coagulation. So heparin, at least in vitro, has the ability to neutralize many of these harmful effects. So in terms of its ability to target multiple pathways, obviously it will inhibit coagulation, but it has the potential also to inhibit platelet activation, to reduce endothelial injury, and to suppress the expression of tissue factor on circulating monocytes. So how will we actually test this in a preclinical animal model? In other words, is there an optimal time frame to administer heparin? So this project has recently been funded by CIHR. I'd like to acknowledge many collaborators, including members of the National Preclinical Sepsis Platform. Manoj, I see you back there, as well as the co-leads, Asher Mendelson, Braden McDonald, and Allison, as well as others. So one of the benefits of this model of sepsis, and every model has its limitations, is that we're simply injecting live bacteria into the abdominal cavity of mice. The bacteria are harvested from rats, and we store them in multiple aliquots so that it's a standardized batch. By doing this, we know when sepsis starts, and then we can ask the simple question, can we administer heparin, or is there an optimal time frame to administer heparin that will improve survival? By collecting organs as well as blood and quantifying bacterial loads, we also have the opportunity to understand at the mechanistic level how heparin actually improves outcome. We also have 4 different heparin variants that differ in their size as well as their anticoagulant properties. So unfractionated heparin is the largest heparin. It contains the antithrombin binding sequence. There's also low molecular weight heparin, also known as enoxaparin or dalteparin, which is a smaller heparin, and because it is smaller, it has the ability to selectively inhibit factor 10A, which is an enzyme higher up in the coagulation cascade. Vasoflux is a small heparin that has been chemically modified to remove its anticoagulant properties. And then we've got fondaparinux, which is an ultra-small heparin that only has antithrombin functions. The third barrier is that there's heterogeneity in the patients and process of care. Will one size fit all in the treatment of sepsis? So as we heard in the previous presentation, there are significant knowledge gaps in terms of prognostic enrichment and also predictive enrichment. For predictive enrichment, this would be useful for targeting therapies based on biological mechanisms. So several years ago, we decided to collect longitudinal blood samples from ICU patients with sepsis. And this was a multi-center study of 9 ICUs. This was called the dynamic study. And we hypothesized that a combination of some routine clinical parameters as well as some investigational biomarkers may be useful for generating personalized mortality risk profiles. What we found is that there are 6 major indicators that can predict poor outcome. These include low platelet count, high lactate, high levels of creatinine, abnormal Glasgow coma score, high levels of circulating DNA, and low levels of protein C. What we found is that there are individual mortality risk profiles for each patient. So we think about targeted therapies, there could be patients with very high levels of DNA at ICU admission that are persistently elevated. So those may be the patients that would benefit the most from DNase therapy. Other patients have very low levels of protein C, which is the natural anticoagulant. These patients may benefit from heparin therapy. And similarly, those with increased inflammation, IL-6 receptor antagonists may also be a potential option. So just sort of to summarize our preclinical research, we're looking at new interventions, including DNase 1 and heparin. We're also trying to identify the optimal timing to administer the therapies, and then developing a targeted approach for prognostic as well as predictive enrichment. And then ultimately, the goal would be to select the right treatment at the right time for the right patient. And I'd just like to thank many past and present members of our lab, and very happy that the new group of trainees are here. So shout out to Zara Khan, Harmon Bogle, Angela Billick, Maggie Chan, and Selena May. Alison Fox-Robichaud, many members of the Translational Biology Group, Manoj and Asher and Braden with the National Preclinical Sepsis Platform, and also collaborators at Montreal and McGill. Thank you. Yes?
So thank you. It was really interesting. I always love these basic science talks that I can actually think about, relate it to when I'm treating patients. As an intensivist who remembers activated protein C, I'm wondering what your sort of understanding of the potential cost of this DNase might be if it was to ever get to like actual real-world clinical use.
So in terms of activated protein C, for those who are more junior, activated protein C is a naturally occurring anticoagulant that was approved by Eli Lilly for the treatment of sepsis back in the early 2000s. It was used, I believe, for around 10 years, but then it was taken off the market because when they tried to repeat the phase 3 clinical trial 10 years later, they weren't able to show a survival benefit. I actually still have a vial of activated protein C in my kitchen fridge. It's tucked in between the ketchup and the mustard. Allison is convinced that it does work, and I think the challenge is that it was administered to such a heterogeneous group of patients that it was not possible with the sample size to see a survival benefit. So in terms of recombinant DNase 1, I think the budget for the grant was something like $44,000 of the drug for 36 patients. I think it's something like $400 per patient, something like that. It's not hundreds of thousands. Yeah. It is, yes. So we break open the vials, and then in a sterile biological cabinet, the drug is transferred into saline mini bags because it's not given as an inhaled substance. And the mini bags are administered over 30 minutes, I believe.